This patient has undergone previous cataract implant surgery with implantation of the intraocular lens into the capsular sac, and as can be seen here, a fairly wide YAG laser posterior capsulotomy. The problem is that the patient has very, very significant negative dysphotopsia. So the plan here is to free the optic from its attachments to the capsule and prolapse it anterior to the anterior capsule, so-called reverse optic capture. So we're going to begin by making two side port incisions on opposite sides of the eye. That's the entry through which we'll eventually prolapse the optic. And here I'm going to stain the anterior capsule if I can, because it's kind of difficult to see the edges of the anterior capsule with the edge carrier on the optic, if you will. So I'm now irrigating the trypan out of the eye and aspirating these bubbles. And now I'm going to inject OVD distal to the remaining bubbles. The staining of the anterior capsule here is mild. Maybe it'll help us to visualize the anterior capsule, however, during the prolapse procedure. So just aspirating now these bubbles so that we get the best view, and now I'm going to make a little side port incision over here. And through this incision I'm going to insert a 30 gauge needle with visco attached to it and see if I can visco dissect the anterior capsule and free from the IOL. And we want to do that, of course, over a haptic where the posterior capsule is protected. So I happen to be trying this now beveled down and sliding underneath. And then when I think I've gotten far enough underneath the capsule, I'm going to inject. And you can see to the right there the OVD dissecting between anterior and posterior capsule leaflets. It typically won't go too far, however, because with an open posterior capsule, the path of least resistance is going to be posterior. So now through this side port, doing the same thing now with a cannula, trying to get some visco dissection and freeing of the optic from the surrounding capsule. And you can see the OVD moving out into the periphery there. Not necessary to free the haptics. In fact, we don't really want to free the haptics. We want to free the optic. So now from the other side, kind of tire ironing around and getting separation between anterior capsule and optic. So now with the spatula, you can see the anterior capsule there being displaced a bit on one side, and now on the other side, similarly, I'm trying to push the optic over the inferior, if you will, spatula and prolapse that optic. Checking over here. Now I'm going to try to get this spatula underneath again, and using the spatula from the side, again trying to get this optic to shift anteriorly to the rhexis. Looks like we're just starting to get it there to be anterior on that, what is the nasal part of this eye. And now it appears to have been prolapsed, and I've got a spatula underneath elevating the entire optic so that now the entire optic, except at the haptic optic attachments, is anterior. Now of course we want to be sure it's going to stay there. So looking at it here, want to one more time go in with the spatula here and verify that this capsule on this side is underneath the optic. The same thing on the proximal side here. And now in this final view we can see that both the nasal and temporal aspects of the optic have been captured anterior to the anterior capsule, and it now would remain only for us to carefully irrigate the OVD out of the anterior chamber without pushing the optic back behind the anterior capsule as we do so. And following the OVD irrigation from the anterior chamber, we would typically inject a miotic agent such as myostat in order to reduce the chances of an intraocular pressure spike in an eye in which we probably are not going to remove all of the OVD.